evening, friends. Today's topic of discussion is Vesico Ureteric Reflux. This is an important pathology which it appears on the face would be of pediatric interest, but you will be surprised at how many adult patients also present with this phenomenon. Before I actually discuss the incidence and its implications, etc., it's very important for you also to know that this will be one of the very important short notes in your examination. So, and secondly, the nature of the pathology is very interesting in the sense it's a congenital pathology with any number of surgical procedures that have been developed in order to reduce its impact on the kidneys. Now, if you have to define it, then it can be defined as a retrograde regurgitation of urine. That means normally urinary flow is antegrade, isn't it? So here it would be a retrograde regurgitation of urine from the urinary bladder up the ureter and into the collecting system of the kidneys. So now, if suppose it can result from several anomalies and related to the functional integrity of the ureter, we'll talk about those anomalies. And it also depends on the dynamics of the bladder. That means if you have normally the dynamics of the bladder is it fills up when the urine is formed, and it fills up without any increase in the pressure up to a point. And beyond a point, when the pressure rises to a certain level, it empties itself. That is the dynamics of the bladder. And at that point of time, when the detrusor contracts, the internal sphincter opens up, the internal orifice, vesical orifice opens up, and the urine is discharged. Supposing for any reason, the detrusor is contracting, but the internal sphincter does not relax, then you have a problem. The pressure rises to a very high level, and this can produce the Vesico Ureteric Reflux. We will discuss that in a short form as we go along the lecture. And the anatomical composition of the uretrovesical junction is also very important. And we'll talk about it in just a while. Now, what are the implications of Vesico Ureteric Reflux? And how often does it affect the people? It approximately affects 1 to 2% of all children. That's quite a lot if you consider the birth rate in our country. And up to 1/3 of these children with VUR will also experience urinary tract infection. Now, this is actually a very important sentence because the urinary tract infection is the one that causes maximum damage. And that is what we'll try to be avoiding, whether it's medical treatment or surgical treatment. And so therefore it is important to connect up the VUR with the urinary tract infection. And this infection can lead on to acute pyelonephritis. And as a result of that, you can have renal scarring, right? And so if supposing renal scarring takes place extensively, then it can lead on to CKD. And so this whole pathology is called reflux nephropathy. That means nephropathy or a nephric disease that has occurred because of reflux. So this is exactly the point of the whole lecture, that you will have to prevent urinary tract infection in children, and you will have to ensure that they do not have acute pyelonephritis and subsequent scarring and CKD. Now, this is the implication for children. What about the adults? Adults also present with VUR, but because of different conditions, which I'll show you in the etiology, and they also go through the same pathology. So therefore, if there is a reflux going on, then you need to think of preventing urinary tract infection and also think of correction if it is present on a long-term basis. And in severe cases of reflux nephropathy, about 10 to 25% of patients will develop an end-stage kidney disease. And this, as you can imagine, is a very serious implication. We need to think a little bit about the anatomy and the pathophysiology. I will not go into too many details, but at the same time, those details which actually apply to our problem. And I hope that you also remember something about the development of urinary tract, right? Broad definitions, I'm sure you remember, develops from the pronephros, mesonephros, and metanephros, right? These are three components going from above downwards, craniocaudally. That means pronephros is in the embryo, in the cervical region, and mesonephros is in the thoracic and upper lumbar region, and metanephros goes down further from the upper lumbar into the pelvis, right? So that is how they are placed in the developing embryo, right? That all takes place somewhere between the 4th to 6th week of embryonic development. What is important for us with reference to the subject that we are now talking about is the metanephros, right? Metanephros, the tubules will disappear as far as the functional aspect goes, but what will remain is the duct of the mesonephros. And the duct of the mesonephros is known as the Wolffian duct, which you may have heard of already. And from that duct will arise, from the lower part of the Wolffian duct will arise the ureteric bud, right? So development of ureter starts from this ureteric bud. Ureter elongates in length as well as it travels upwards into the lumbar region. And the tip of the bud will actually, there are specific substances, I'm not going to discuss that now. The tip of that bud also controls the development of the nephric tissues from the metanephros, right? So that is how this junction, this point where the ureteric bud arises from the Wolffian duct, that is the point which will become the future ureterovesical orifice. As you can see in the diagram here, I have drawn here ureteric bud and the mesonephric duct and how the process of elongation is taking place. So now, and this is the mature kidney in the diagram, which all of you will easily recognize. The trigone and the uretrovesical orifices, they are also visible. It's also important to know something about the structure of the ureter with specific reference to our topic. Now, the ureter has got 3 layers, right? An outer adventitial layer, and an intermediate muscular layer, and an inner mucosal layer. The mucosal layer is transitional epithelium, and it is waterproof because of the presence of keratin. And just outside that, the very thick lamina propria. And then starts the muscular layer. Muscular layer, there is an outer longitudinal, intermediate circular, and inner longitudinal. That means the circular layer is sandwiched between the 2 longitudinal layers. And just outside that is the adventitial layer. Adventitial layer is, of course, the place where all the nerves enter, the blood vessels are placed, and ureter takes its blood supply from various sources, as you must be already knowing. And in the pelvis, it enters medially, and up above, it enters laterally. So now let us trace the ureter from above downwards and what happens near as it approaches the uretrovesical junction. What happens is it gets closely applied to the detrusor first, and then ultimately penetrates the detrusor and travels, it tunnels through, that means, and travels submucosally for a certain amount of distance, maybe around 2 to 3 centimeters, and then enters the uretrovesical orifice. Now, this travel submucosally is critical because this is what is responsible for the prevention of the reflux, the retrograde flow of urine. And if supposing by any reason this tunnel is short, that means less than 3 centimeters, let's say 1 centimeter, this tunnel is very short and there isn't enough detrusor backing, then it does no longer function as a flap valve. Now let me explain this a bit, that when the detrusor contracts, the uretrovesical orifice, the detrusor around the orifice also will contract and press the 2 layers of the mucosa together, and this acts like a valve. And this prevents the reflux of urine into the upper tract. So this flap valve mechanism is what is disturbed in a case of UV reflux. And that is why this development here is important. That means entry into the bladder, tunneling submucosally, and then ending at the uretrovesical junction. This is a very critical part of the anatomy of ureter. I have three diagrams here, one mature full system and the other one the bladder itself with the ureters traveling submucosally in the form of a tunnel. And that is being shown very clearly here. And so now let us move on. After a brief discussion of this anatomy and pathophysiology, let us now move on to the next slide,